Welcome everybody as we continue this work to understand long COVID and introduce long COVID as a concept. This presentation is going to be all about what we call the pathobiology of long COVID. So starting to understand what's happening in the body that is causing the symptoms that we see when patients present to us with long COVID. I wanted to start off with just a quick reminder that what we're talking about here is this syndromic long COVID that we were speaking about in the last module. So this is less about folks who have long COVID as a result of direct acute organ damage from their acute illness, and more about folks who have survived their acute infection. Maybe their acute infection was not even that severe, and yet they're starting to experience severe dysfunction, severe debilitation, and we can't see why on mainstream medical testing. So that's what we're going to be talking about here when we delve into the pathobiology. So the first step in this, I think, is really conceptual. How should we be thinking about the pathology of infection-associated complex chronic illness? It shouldn't be the same way as we typically think about, less complex illness. And so I wanted to start off with just a few principles to begin. The first concept that I think everybody should embrace in this is these folks are going to come to you and they're going to test normal for everything. This doesn't mean that their physiology is normal. This means that we either don't have the available testing yet in a mainstream setting, or we're not testing the right organ systems to identify and highlight the dysfunction that we're seeing and the symptoms that people are reporting to us. So, I want to really highlight this because it's such a common story for people who are experiencing long COVID symptoms. They will go and they'll get every test under the sun, and the tests, the tests come back normal, within normal limits, we call it, or even they'll come back abnormal. So they will see some abnormal measurements, but those abnormal measurements are difficult to interpret. We don't quite know why a certain level is low or a certain level is high, because it's not testing abnormal in a way that we're accustomed to and know what to do about. And I think that, the big concept that needs to be said over and over again is long COVID is an organic disease. What I hope to really instill within you in this session is the idea that we do understand some of the pathobiology. It is very objective. It is very clear to see that there is something demonstrable occurring in the body that is causing the symptoms of long COVID. And people with long COVID have measurably different physiology to folks who do not have long COVID. So if you're a skilled clinician treating someone with long COVID and all of their tests return normal, that's where you begin. That's the beginning of your investigation work. It's not the end. So this is really conceptually how we should be thinking about it. And finally, just one last reminder that as clinicians, we should be working our hardest to treat someone who comes to us in a critically sick state. Don't ask someone who is incredibly ill to prove to you that they're ill just because their tests are returning normal. If they're telling you that they're symptomatic, that means they're symptomatic. I would remind you, from our first lecture, long COVID is a clinical diagnosis. That means if someone comes up to you and tells you that they're feeling ill, you can diagnose them with long COVID. You don't need a test to prove it. So really extrapolating on that point, we don't need tests to prove that someone is ill. We just need to continue to search for the clues to what is causing the symptoms that they're presenting to us with. I'm very sort of adamant on this point because I think it's really important to acknowledge as clinicians that there has been a lot of abuse in the past. We think about long COVID as what we call a post-acute infection syndrome. And there are many post-acute infection syndromes out there in the world. Others that exist are myalgic encephalomyelitis or chronic fatigue syndrome, long Lyme disease or Lyme plus, any of these tick-borne or vector-borne illnesses, and even forms of dysautonomia that can be triggered by other viruses in the body. So many of these illnesses exist, and people with these illnesses, these post-acute infection syndromes, have really experienced what can only be called a shameful history of gaslighting, denial of service, low standard of care, rejection of short and long-term disability claims, and this has persisted for decades. We really have an opportunity here as clinicians to stop this cycle of abuse and stop this cycle of medical gaslighting by understanding both the poor science and the poor treatment that has occurred in the past, but also the new generation of science that is emerging that is highlighting the fact that these individuals have been right all along as they've told us about their symptoms and come to us with a reasonable expectation of care. So we owe it to the community, both the long COVID community and those with other post-acute infection syndromes, to educate ourselves on this and be knowledgeable about what has gone before so that we do not repeat the mistakes of the past. And so with that in mind, I want to point out the idea that as you try to understand the pathobiology of a complex chronic illness, we need to acknowledge that it's a moving target. This is work that we just recently published, myself and a collaborator, the wonderful Akiko Iwasaki from Yale University, where we show some of the main drivers of the pathobiology of long COVID, being viral persistence, which is this red cogwheel up here, the viral reservoir, autoimmunity, this blue cogwheel, latent virus reactivation, the green cogwheel, and then general tissue damage and dysfunction, this yellow cogwheel. And we built them out as cogwheels because what we're trying to express visually here is the idea that each of these is influencing the other, maybe making things worse, maybe making things better. And then each of these, both individually and together, are causing a cascade of other symptoms and other dysfunctions that really lead us toward severe symptomatology. And so, really what I want everyone to understand is what this means is that biomarkers and things that we test for in long COVID can really be moving from day to day. One day you may have overt evidence of latent virus reactivation, and other days there may be none at all. Some days we may see very clear evidence of endotheliitis and platelet hyperactivation, and yet the next day cleared up, nothing at all. This is because these are dynamic structures, these are dynamic processes, and so they can cause a lot of trouble without actually sticking around and showing us biomarkers day to day. And it also means that unlike with conditions that we know a lot about, so someone who's showing up with low back pain as a result of a disc bulge, or someone who is showing up to us with a sprained ankle from a tear of the ATFL ligament, when you're dealing with complex chronic illness, you need to become more of a specialist generalist rather than quickly referring out to specialty care because, this looks like an immune system thing or a neurology thing or, a musculoskeletal thing. When you're dealing with complex chronic illness, you need to have the confidence as a provider to know a little bit about all of the systems so that you can helpfully advise the patient on what's happening in their body and what's going on. And then, the other thing I'd like to acknowledge on this front is just the idea that the way that this is already complex, but the way that these complex systems interact with pre-existing conditions such as diabetes, lupus, Hashimoto's disease, Crohn's disease, other autoimmune conditions, it's largely unknown. So we do have this blank canvas of a lot of people who are getting long COVID who are previously fit and healthy, but we also have a lot of people who were not previously fit and healthy, and long COVID is affecting their system in a myriad of different ways as well. So we still have a lot of work to do to understand what's happening. But let's focus less on stressing out about how complicated and diverse and worrying that this whole condition is. And let's focus in a little on what we do know right now. So to that end, I mentioned this in our previous session, but I'll mention it again. Long COVID can involve every single organ system. Some of the time we know what is happening to drive the organ system dysfunction. Other times we really don't just know yet. But regardless of whether we're talking about direct damage from the acute virus or subtle organ dysfunction from reduced circulation from endotheliitis or slight changes in our hormonal output that cause dysfunction of different organs, we're seeing a widespread impact on the body. And like I mentioned, we know something about the mechanisms in some cases, but in other cases, it's very much unknown. And it's also worth mentioning to make things a little more complicated. Some symptoms will have one very clear driver, and other symptoms could be happening for lots of different reasons. For instance, you could be having a headache due to endotheliitis, due to dysautonomia, due to mast cell activation syndrome. So an immune cause, a neurological cause, and a vascular cause could all be responsible for a persistent headache. Sometimes it could be all three. And having a general understanding of the underlying pathobiology is super important because it gives you a better understanding and a better appreciation for the fact that combination therapies may be necessary to clear some of the symptoms that people are experiencing. It won't just be physical therapy to the rescue and the headache goes away as soon as you've completed autonomic rehabilitation. No, you may need autonomic rehabilitation paired with antihistamines, paired with other medications to improve blood flow. So keeping in mind that given the complexity and given the diversity of symptoms affected, we always need to be thinking about interdisciplinary care and how many treatments in combination may be the answer to making our patients functional. A recent study in Nature Microbiology showed us that there are really 5 most likely underlying causes of long COVID pathology. So there's 5 things that are most likely going wrong that drive a lot of the pathology that we see. And they are in no particular order. Immune dysregulation, so the immune system being knocked out of balance either by persistent virus or sometimes what we call molecular mimicry. So the virus is gone, but the body still thinks the virus is around. Dysbiosis of our microbiome. So as many of us know by now, we have colonies of different bacteria living on our body. This constitutes our microbiome. And sometimes if those bacteria colonies that are living in a delicate balance themselves get knocked out of balance, it can cause the host, us, to become very unwell. And we know that that COVID-19 has the potential to disrupt that equilibrium. We also know that due to the significant immune response that COVID triggers, some people can be pushed into autoimmunity, where the immune system begins to attack the body itself. And this can be a very challenging cycle to break, and it can be incredibly damaging to the body while it's in motion. We have now had some very impressive and emerging literature to show that folks with long COVID experience what we call endothelial dysfunction, so dysfunction of the inside of a blood vessel, which leads to abnormal blood clotting, as well as hyperactivation of platelets. So this is something that we're starting to really dig into from a pathobiological standpoint. And then finally, the virus can also affect the nervous system heavily and significantly. So I'm going to move into providing evidence for each one of these underlying causes now in a little bit more detail. Let's start with immune dysregulation. So in the journal Gastroenterology, we see here this idea that individuals with long COVID are showing fragments of the virus persisting in their intestinal tissue for months and months, several months after their infection. So this was a really important finding for folks with long COVID, where it really showed us that there is something going wrong with the body's ability to clear the virus in around 60 to 70% of people with long COVID. Similarly, in clinical infectious diseases, David Walt's team out of Harvard published a wonderful paper showing that around 60% of folks with long COVID were showing evidence of circulating spike proteins in their blood at 12 months post-infection. And this was as compared to 0% of individuals who did not have long COVID showing circulating spike proteins in their blood. So however you take this, there is very clear evidence to show that around 2/3 of folks with long COVID, maybe more, are showing us evidence that somewhere in their body, somewhere hiding away in their body, is persistent virus, fragments of old virus, and spike proteins that could be continuing to cause an immune response that continues to cause damage. Building on from that, we have seen in our own work, again, this is in collaboration with Akiko Iwasaki's group at Yale, and this is in a paper that is currently under review in Nature, where we're able to show that folks with long COVID compared to control groups, so these two controls here are a first control group that has never had COVID, so an entirely COVID naive group, and then another group that has had COVID and fully recovered. When we're looking at both their T cell activity, both CD4 T cells and CD8 T cells, which are different forms of T cells that are involved in different types of immune responses, we see that the folks with long COVID have extremely elevated numbers of activated CD4 and CD8 T cells. This tells us, without delving right down into everything to do with the immune system, what this tells us is the immune system is fighting something. This is also, this finding is also tempered by a finding in Nature Immunology, where the authors there showed that individuals with long COVID had persistent elevation of different combinations of inflammatory cytokines. These are, again, immune cells that are indicating that our body is trying to fight something off. And they're persistently elevated in folks with long COVID, so much so that in this particular Nature Immunology study, they were able to show that they could predict with around 86% accuracy who had long COVID and who did not, just from presentation of these inflammatory cytokines. So the bottom line with what we're seeing in immune dysregulation is that a large proportion of people with long COVID are, when we really do a deep interrogation of their immune system, this is, I will acknowledge once again, these are not mainstream tests. These are research grade tests where we're really doing significant profiling of these patients. We're starting to see that a large proportion of them show concrete objective evidence of immune dysfunction, whereas individuals who do not have long COVID are not showing these signs and symptoms. So that's a couple of examples of immune dysregulation. Now let's move on to microbiome. So once again, we just have some really great studies. So this is a really wonderful image that was taken from the Journal of Medical Virology, showing us that not only can we say, yes, there's some sort of microbiome and gut dysbiosis occurring in people with long COVID, but actually we can actually start to specifically identify the good bacteria that are getting decimated by the ongoing inflammation in the gut, and the bad bacteria that are being encouraged to overgrow as a result of the inhospitable and inflammatory environment that is occurring in the gut after a COVID infection. So this is emerging literature, but it is being published in very prestigious journals. The Journal of Medical Virology is a great high impact journal, and we're seeing that individuals with long COVID are much more likely to experience gut dysbiosis than their peers who do not have long COVID and have fully recovered from COVID. Moving into autoimmunity, similar to the immune dysregulation process, what we're seeing again over and over again is multiple studies showing evidence of autoimmune processes occurring. Now, the idea here with autoimmunity and how it is different to regular immune dysfunction is, in the first set of slides and images about immune dysfunction, I was telling you that it looks as though our immune system is fighting something off, and it's using, regular immune cells and regular immune approaches to fight off an intruder. In this case, we're also starting to see individuals who are producing what we call autoantibodies. These are antibodies that, rather than being designed to fight off pathogens and invaders, these antibodies are being designed to attack the body's own tissue. We don't exactly know why the body is turning to this resort. Maybe it is because, there's embedded pathogens in our own tissue and it's confusing the body. But whatever the cause, what we're starting to see once again in really well-conducted studies that are published in very prestigious journals like Cell, we're starting to see that these persistently circulating autoantibodies are not only predictive of people who go on to develop long COVID, but they're also being associated with distinct patterns of long COVID symptoms. So we really start to see that there could be a autoimmune subtype of long COVID amongst all of the folks with long COVID who are coming to our clinic. Moving along to endothelial dysfunction and disorders of clotting. I think this is possibly one of the most important discoveries of this decade, even as we start to think about long COVID and folks with long COVID, because it's an entirely new paradigm to think about through the lens of complex chronic illness. So we're starting to see a majority of long COVID patients, in many studies, more than 90%, are starting to show this evidence of vascular pathology and endotheliitis. So the SARS-CoV-2 virus, as we have discussed a few times, the way it gets into the body, the way it actually enters cells, is through a receptor on the cell called the ACE2 receptor. Now, depending on the different organs and organ systems that you're working with, you have differing sort of densities of ACE2 receptors. So for instance, you have a lot of ACE2 receptors in your gut, and you don't have that many ACE2 receptors in your brain. But the place where you have the most ACE2 receptors is in your blood vessels, meaning that it's very easy for the virus to enter cells in your blood vessels, which also means that, unfortunately, if you have a SARS-CoV-2 infection, your blood vessels are going to be where a lot of the damage gets done and a lot of the inflammation occurs. And so the work of a brilliant scientist in South Africa by the name of Rehabilitation Pretorius has started to show that in individuals who get infected with SARS-CoV-2, they start to, their bodies start to produce abnormal clotting behavior, and they form these microclots. So what Rehabilitation is able to do is she takes blood samples, she spins those blood samples down until you've got hematocrit, which is all of the red stuff, and then you've got platelet poor plasma, which is, the straw-colored plasma portion of our blood. But she's spun it so quickly that it actually has taken out all of the platelets as well. Now, what Rehabilitation did in her early work was that she showed that folks with acute COVID-19 were starting to form these microclots. So this sort of smudge that you can see in what used to be completely clear, this is a microclot. So this is clotting that is starting to occur in the platelet poor plasma. Now, a lot of people said to her, well, it's hard to find these microclots. How do you know that it's the virus itself that's causing these clots to occur? And so the next thing that Rehabilitation did was she took platelet poor plasma from healthy controls and she added spike proteins to that healthy platelet poor plasma. And as soon as she did, microclots started to also form in the platelet poor plasma. So what we're starting to see is a pathobiology in the blood vessels, which is characterized by both the formation of these microclots as well as hyperactivation of platelets that are both hallmarks of severe endotheliitis. And in fact, what we're starting to see, again, in a majority of people with long COVID, is the emergence of these microclots. Now, these microclots are not large enough to block major vessels, large vessels, but they are large enough to cause microvascular damage. So we start to see small fiber neuropathy. We start to see changes in people's organ function, but it doesn't look as though their organ is being damaged. So this vascular pathology piece, which continues to get replicated in lab after lab all over the world, is starting to emerge as a very promising field of long COVID research and an understanding of long COVID pathobiology. And so finally, we're going to move into our last piece of long COVID pathology, which is this dysfunctional neurological signaling that occurs by the virus affecting the neurological system. There are many different ways that the virus can affect the central nervous system, and not all of them are well known. We were really fortunate to work with a brilliant neuroscientist by the name of Michelle Mongi out at Stanford University, and we published this work in the journal Cell, where we showed that when you, in an animal model of COVID, when you infect mice with just a respiratory version of SARS-CoV-2, so It just affects their lungs, nothing else. The mice don't get very sick and they recover quickly afterwards. What we were able to show was that even though the virus never left the lungs, it caused increases in cytokines that travel through the cerebrospinal fluid, and it actually started to cause white matter damage in the cortex. So not only did we see this in a mouse model, but we also, in the mouse model, when we isolated the cytokines that were causing the damage and we looked for them in human participants with long COVID, we started to see the same cytokines being expressed in people who reported cognitive impairment, and then when we tested, had measurable cognitive impairment. So we're starting to see this link to, even when you don't have a severe SARS-CoV-2 infection, even when you don't have a SARS-CoV-2 infection that leaves the lungs, even though I just told you that the ACE2 receptor doesn't really present all that much in the brain, so you don't need to worry about the virus directly infecting brain cells, a SARS-CoV-2 infection is still creating cytokine activity that goes on to cause brain damage. Our takeaway here is that no matter how mild your SARS-CoV-2 infection, it has the potential to cause organ damage. So this is why we're seeing so many people come to us with, telling you this story of, yeah, I got COVID, it was no big deal. Now I can't work. Now I can't focus. And what we need to do is understand this pathology and see what we can do to reverse it. But it is a daunting task, and it is incredibly worrying. I would also draw you along to this recent publication in Nature, where researchers took historical controls from the UK Brain Biobank, and they showed that after surviving a COVID infection, individuals who had a pre-existing MRI scan showed a decreased cortical thickness as a result of their SARS-CoV-2 infection. And even more concerning was that in most cases, this change in brain size was also associated with a decline in cognitive function. So they had people completing the Trail A and Trail B cognitive task, where an increased time means poorer performance. So these individuals were performing more poorly at this cognitive task. And while they were performing more poorly, we're also seeing that their cortical thickness is decreasing, and their contrast sensitivity in their brain is also decreasing, indicating less cortical function occurring at rest. So, once again, whether we like it or not, even a mild COVID infection is having demonstrable changes in our brains. And this is something that we need to be very, very, cautious about as we consider infection prevention, as we consider the cost and the damage that reinfection can do. There is no such thing as a mild COVID infection. And then finally, as we consider the pathobiology of long COVID and how it affects the nervous system, we also need to consider the autonomic nervous system, and the fact that roughly 80% of folks with long COVID will have associated dysautonomia. This is incredibly challenging to treat, and in our series, we will go into great detail about how to manage dysautonomia. And although we're still trying to understand the mechanism of dysautonomia, many folks are putting forward the idea that at the time of acute local infection, it's very possible that the vagus nerve is getting transfected, as the olfactory nerve is one of the sites of initial local infection. And so then that infection just passes down into the brainstem and continues down into the vagus nerve. So there's a lot of emerging literature on this, but What we do know is that a large proportion of people with long COVID and this could be as a result of damage to the vagus nerve or inflammation around the vagus nerve after the initial local infection. So now that we've discussed a little bit about the pathobiology, I hope you can appreciate that are being published to show us that there is an active pathobiological process or many active pathobiological processes occurring to produce the symptoms that we're seeing. I really took pains, although this is one of the most well-researched journals like Nature and Cell and Science, journals that have a reputation for being consensus journals. The reason I did this is to really press home the message that this is what consensus science is saying, that there is a distinct pathobiological going on because we don't yet have a mainstream biomarker for diagnosing long COVID. That's fringe science. We should not be listening to that because that is the argument of people who are not up to date with the latest in biomedical research. So now, with that in mind, let's talk about how we're doing with diagnostic. Diagnostic biomarker game is challenging because there are so many different causes of long COVID, depending on who you are and what your past medical history is. But what we're starting to see is that we can get some very informative biomarkers that are helping us to classify out people who have long COVID and differentiate it from people who do not have long COVID. So, for instance, in the work that our team has been doing with Akiko Iwasaki, we see that reduced morning cortisol is currently one of the most discriminating biomarkers that we have. With 91% accuracy, we can differentiate someone who has long COVID from two different groups of controls that do not have long COVID just by looking at their morning cortisol levels, indicating that there is a hormonal component to long COVID physiological dysfunction. What we're unsure about with this biomarker is whether we're looking at something that is adaptive, meaning that somebody's body has changed in a different way, and as a result, they're showing abnormally low cortisol, or if a cortisol deficiency is driving the pathology that we're seeing in people with long COVID. Our theory, our working theory at this time, which is yet to be confirmed with science, is that this is an adaptive response. The reason why is because very few people respond well to corticosteroids, things that increase cortisol levels. So if cortisol deficiency was driving this, then steroids would treat that deficiency and make people feel better. That doesn't seem to be the case here, so we think that what we're dealing with is an adaptive issue. The other thing that I want to point out is that we're really starting to move toward identifying many different targets that are either higher or lower, significantly higher or lower in people with long COVID. So, we explored some of these before, activated CD4 and CD8 T cells. We're starting to see increases in Epstein-Barr reactivation, so latent virus reactivation is increased, galectin increase, so other hormonal increases. So this is a complicated roadmap, and as I said, there's no one biomarker just yet, but we're really starting to see many actionable biomarkers emerging that predict people with long COVID versus people without long COVID. And as you can see here, and again, this is from work that we've been doing with Yale. When you pull together all of these biomarkers, whether it be the reactivated viruses, different antibodies, and anti-COVID antibodies, and different presentations of inflammatory cytokines or immune cells from flow cytometry, what we see over time is that if we take everything together, we can classify people with long COVID with 96% accuracy. So I know that we all want a biomarker. I know that we all want a definitive diagnosis. We're getting there. We're getting there very, very quickly. I would just say that at this point, it's not outrageous to assume that in the next 5 to 10 years, we're going to have a very clear objective biomarker for long COVID, but it's not mainstream just yet. And that's what we're really pushing toward at the moment. With that in mind, I also want to point out a finding of the previous study, which was when we tried to diagnose people with long COVID or not long COVID based on their physiology, based on stuff that we were able to take from their blood, we were able to do it with 96% accuracy. When we also tried to diagnose people with long COVID or not long COVID, just based on the way they subjectively reported their symptoms to us, we were able to do it pretty well with around 92% accuracy. And when we asked the question, okay, we've got two algorithms, one that is diagnosing people based on their blood biomarkers, one that is diagnosing people based on the way they say they feel. Are the two algorithms diagnosing the same people as having long COVID and the same people as having not long COVID? When we asked that question and we ran an agreement algorithm, what we saw was near perfect agreement between the two. So what that tells us is right now, at this moment, as we're searching for objective biomarkers, listening to your patient, just hearing what they're telling you about their symptoms, that's the only biomarker that we need right now. So again, I would urge you to just remember that the CDC tells us long COVID is a clinical diagnosis. Listen to your patients. Believe them when they're telling you that they feel unwell. And those are the only biomarkers you need to prove that someone has long COVID. So thank you so much for listening. I know that was a heavy session. And up next, we're going to talk about our overview of clinical pathways for long COVID and how we think conceptually about how to treat it.